Good morning, and welcome to the world of fusion cytokinetics. This is your weekly podcast. I am your host, Kweni Bagri, the cytokine enthusiast. Today, we shall be taking an adapted excerpt from Neri and List et al. 2013 on immunocytokines. Today, we shall be looking into special interest of interleukin-12 based immunocytokines. But first, let us assess interleukin-12 immunology. Interleukin-12 is a 70 kilodalton glycoprotein and heterodimer consisting of a P40 and P35 moieties covalently linked via a disulfide bridge. It is produced by dendritic cells, monocytes, macrophages, neutrophils, and B cells in response to recognition of pathogens. For example, through toll-like receptors, interleukin-12 mediates both adaptive and innate immunity by stimulating the production of interferon gamma in resting and activated peripheral blood lymphocytes, stimulating natural killer and T-cell effector functions and promoting MHC1 processing and presentation. Interleukin-12 has also established anti-tumor activity in animal models and in humans. There is a synergistic effect between interleukin-12 and other cytokines. In particular, the combination of interleukin-12 and interleukin-2 has been shown in animal models and clinical studies to enhance multiple immunological parameters such as interferon gamma production. Early clinical trials with interleukin-12 have seen responses in metastatic renal cell carcinoma, Kaposi sarcoma, T-cell lymphomas, and non-Hodgkin's lymphomas, with percentages of responses ranging from 70 to 21%. However, the systemic administration of interleukin-12 has also been associated with significant toxicities, which have prevented further clinical development. Doses of 1 microgram per kilogram were associated with undesirable side effects such as fever, chills, fatigue, anorexia, nausea, and elevated transaminase levels. The maximum tolerated dose for recombinant human interleukin-12 was established at 0.5 micrograms per kilogram per day in humans. By using interleukin-12 with interleukin-19 antibody fused together, a therapeutic effect could be achieved at a 20-fold lower dose as compared with free recombinant human interleukin-12 in mouse tumor models, resulting in the infiltration of macrophages, natural killer cells, and elevated interferon gamma in the tumors. Targeted interleukin-12 was also able to potently inhibit tumor growth in 3 different immunocompetent synergic murine cancer models. Now that is the background on the development of interleukin-12, a rather swift summary. But let's look at current models that are trying to enhance the therapeutic index of this potent cytokine. Today, we shall be looking at 2 in particular. We will be looking at NHS interleukin-12 and BC1 interleukin-12, better known as AS1409. Firstly, let's look at NHS-IL12. Now, it is a fusion protein consisting of the necrosis-specific antibody CHTNT3 in immunoglobulin G format, genetically fused at the C terminus to 2 human interleukin cytokine molecules of interleukin-12, whereby the P35 subunit of interleukin-12 is genetically fused to the 3' end of CHTNT3 heavy chain via a glycine-serine linker, and the P40 subunit, encoded separately, forms a covalent heterodimer with P35. Now, when it comes to the clinical observations with NHS interleukin 12, it is currently in a phase 1 clinical trial for patients with solid tumours to determine the maximum tolerated dose and optimal administration schedule. No clinical data in humans has yet been published. So moving forward onto our BC1 interleukin 12, also known as AS1409, let's look at the background of this model before we pursue its clinical outlook. BC1 interleukin 12 is a fusion protein consisting of the humanized murine BC1 antibody in IgG format, specific for the external domain B, containing a splice isoform of fibronectin, the EDB. This is genetically fused at the C terminus of the Fc domain to the P35 subunit of interleukin 12, which in turn forms covalent dimers to the P40 subunit via a disulfide bridge. The BC1 antibody binds EDB containing fibronectin, although its recognized epitope is different from that of interleukin 19, which we previously stated was used with interleukin 12 to improve the therapeutic index. Now, BC1 recognizes a cryptic epitope localized on the type 3 homology repeat 7, and which is masked in fibronectin molecules lacking the EDB sequence. Now, preclinical studies were taken with BC1, and this was found to be successful in murine models having elevated interferon gamma and other immunomolecules to show a fight against the tumor. So moving forward from xenogenic murine metastases and subcutaneous tumor models using these SCID mice, it's actually been possible, unlike the NHS interleukin 12, to be able to carry out studies in humans. AS1409 has completed a phase 1 clinical trial, and we now believe to have found a possible tolerable administrative dose for patients. Now, with this in mind, it is believed that 6 cycles at doses of 15 micrograms per kilogram in humans was the maximum tolerated dose, and doses above this at 25 micrograms per kilogram were found to be toxic. These dose-limiting toxicities were at a grade 3 and grade 4 level of fatigue, anemia, elevated transaminase levels, and this is all indicative of severe liver damage. But this was only observed in doses above 15 micrograms per kilogram per week. Some grade 2 toxicities also appeared, such as pyrexia, fatigue, chills, headache, and vomiting. Overall, toxicities of the BC1 interleukin 12 immunocytokine were lower than those reported for interleukin 12 alone, providing further evidence for a loss of biological activity of the payload upon antibody fusion. And this is beneficial and has set the groundwork for the development of a phase 2 clinical trial. This is currently being developed by Saturn Biosciences Ltd, and they're in need of £7 million to fund this research. Now, this can be a great humanitarian progress through medicine via the use of immunocytokines. Currently, it is a novel therapy, but the future is not sure. Progress may come if there's correct funding. So to any possible investors, please go to our website, follow the link, and click on Contact Us, and send an inquiry into the development of AS1409. Thank you very much. Next week, our podcast shall be on competitors for the treatment of metastatic melanomas. Thank you very much. This is your host, Quenny, signing out.